of the Philadelphia. We're going to go through the Philadelphia 7 Region Initiative data, and we'll round it out with the resources, upcoming events, and reminders. So before we get started, not before we get started, let's move on to the updates. And we have Sarah Duckett with us. And Sarah is the manager for the Outpatient Pilot Registry. So Sarah, I'll let you go ahead. You want to take control?
I'll let you keep control, Rhoda, if you don't mind. I'll just
No.
ask you to move the slides forward, if that's okay.
My pleasure.
Alrighty. Hello, everyone. Thank you for allowing me to speak on this call. So I really wanted to just give you a quick update on outpatient. We are coming to the end of the recruitment phase for the outpatient portion of IHF. So I wanted to give you a quick overview of the registry, the metrics, and the timeline for implementation. We currently have health centers in contracting for the registry in the Chicago market, St. Louis, Milwaukee, and Kansas City. So for the 7 region learning collaborative calls, there will be a nice representation from a variety of markets, which will be nice when looking at the data across the different regions. And for background purposes, our traditional outpatient recognition programs have been more from a numerator denominator only aspect, where now we are able to move more to the patient level data and shifting more towards the extensive filtering. So in addition to the heart failure metrics that you get as being a part of this initiative, you'll also have access to a multitude of other metrics such as hypertension, diabetes, cholesterol, and other chronic conditions. So really our goal here is for you to have the capability to drill down on the patient level experience instead of just filtering on the basic measures. So in order to collect the data with ease and efficiency, we would be connecting directly into your EHR via Firebase APIs, which is nice because that takes away the manual abstraction and makes it more of an automatic process, which is always nice, and it saves a lot of time and money on that. Some of the benefits of the registry are that you can track and improve performance over time. You can benchmark against other Implement HF participants. You can identify patients needing follow-up, and you can compare data between providers and practice locations. And then also you will receive a $25,000 stipend for being a part of the initiative. And if you'll move to the next slide, please. So here are the specific metrics we are looking at. The first box shows the heart failure therapy performance metrics, which align with what's being looked at and tracked on the inpatient side. And these measures have been updated and reflect the most recent guidelines that came out. And additionally, we are looking at general heart failure metrics as well as other chronic conditions. And if you'll move to the next slide. So I wanted to give you a visual timeline for the different phases associated with the outpatient registry so you can get an idea of the process. So after contracting is completed, the focus will be heavily on connecting to your EHR and working with your technical teams. And after that, we will be working with the clinical teams on some QI exercises and then further working with them on the quality improvement aspect of the project. So this is a really great tool to be able to look at and track outpatient data over time, which is not something that we currently have on the patient level, and also to further the continuum of care. So we would love to have representation from the Philadelphia market on the outpatient side for this initiative. And since we are coming to the end of the recruitment phase, if you would like to be a part of this, if you'll let Rhoda know, or if you want to have further conversations, I'm happy to get on a call with you because we would still love to have you join this outpatient side. And I'll pass it back to you, Rhoda.
Thank you. Just as a reminder, everyone, Sarah is handling our Implement HF outpatient. Previously, you may have had contact with Christina Sturging, and Christina is no longer with AHA. So do not use the email for Christina, because we will not be able to contact you. We won't know that you've contacted us about outpatient. So either Sarah or myself. And we really would like to have a New Jersey outpatient representation. And thus far, we don't have that. Thank you, Sarah. Appreciate it. Does anybody
Thank
have any
you.
questions they want to ask Sarah before she goes? Oh, having heard none, I'll just move on. Thanks again, Sarah. Hey, let's see. Let's take a look at the Philadelphia 7 Region Initiative data. I don't believe that Dr. Wall has joined us yet. Correct?
I don't see it, Rhoda.
Okay. So I'll go on through it, and what we'll do is just circle back around when she comes. So let's take a look at the demographics for the Philadelphia. These are the demographics for the Philadelphia region. As you can see, what we have is, it looks pretty much like the Implement HF demographics. And you'll be receiving these slides and, of course, the recording. And so you'll be able to look at this much closer. What we're looking at is the Hispanic population appears to be the largest population. Well, no, actually, it doesn't. White population is 62.6%. But what I was saying is you'll be able to look at this in detail once you receive the slides. These are our inpatient measures that we're using for Implement HF. This is the Philadelphia quarterly inpatient data. I am delighted to say that regardless of where we started at Q1 of 2021, Q2 of 2022 is an improvement. And I'd like to just highlight the ACE, ARB, and ARNI. And Q1 was 86.8, but Q2 of 2022, we're talking a year later, 98.2. The evidence-based beta blockers, we went from in 2021, 91.8 to 97.4. The aldosterone antagonist from 56 in 2021 to 76.6. The ARNIs, a tremendous amount of growth, improvement in use. ARNI at discharge, 43.8 in 2021 to 85%. The health-related social needs assessment, this won't surprise anybody because we really weren't looking at it then, and now we are. It was at 0.4, and now it's at 78.3%. The quadruple medication therapy, at 2021, 10.7, and now 60.6. Of course, we've still got some great improvement there, but we've got some growth still opportunity there. The SGLT2 at discharge in 2021 was 7.7, and now we're at Q2, 41.6. Again, that's an opportunity for growth too. But no matter where we were in 2021, there's been tremendous amount of improvement. And as they always say, what you look at is what improves. You can't fix something if you're not looking at it, and you don't know where you are if you're not looking at it. And it's clear that we're looking at it, and you can see the gains that have been made. So this next slide is the Q1 2021 and Q1 2022. Now, looking at this slide, you can see that there, as I've said before, nothing but gains all the way across. And so improvements have been made, and it's been a continuous improvement. This one I find to be terribly interesting. This is the baseline. The baseline was quarters 1 and 2 of 2021 as compared to Q1 of 2022. And having said that, let me also say that the real goal for Implement HF is to be at 85% for the measure, or 20% increase from the baseline. We've got some room for, of course, some improvement. And in looking at this, you can see the baseline for my biggest concern would be the health-related social needs. You can see how we have grown tremendously from where we were at baseline to where we are now. The ones that cause great, well, I won't say great concern, but some concern would be the quadruple therapy medication for patients, and of course our SGLT2, all improved without a doubt. But I'm thinking we have opportunity there. This is a comparison of the Philadelphia region and Q1, as I was saying, the concern I have would be in this defect-free quadruple therapy medication for patients. I think this is an area that we really could show some work on. This slide bears some explanation. One of the issues we have with the Philadelphia and New Jersey data is that there was no collection of 30-day data in quarters 1 through 4 in 2021 because no one was collecting it. We now have data for the 30-day for Q2 2022, which is why those are zeros. And without a doubt, it's good to see this data, but I would encourage us to now that we've kind of gotten into the initiative, that we really need to start working on trying to get the 30-day data into the tool, because we can't analyze it if we don't have it in the tool. Now, I would also like to bring to your attention that the ARNI and SGLT2 is being fixed. And so that's why you see those are being repaired. And we will have those so that no data is being pulled for those, but I should have those for the next call. Now, of all the data we've got, this is the one that I like the most for the 30-day. You can see the difference between what Philadelphia has for 30-day, Q1, and the 7 region. And granted, the 7 region has more. Explanation is some of the 7 region implement HF data. Those sites were part of the Get With the Guidelines 360. So some of them were already collecting some of the 30-day follow-up data. Philadelphia and New Jersey, as I previously stated, were not. So we're playing catch up, but that's fine. The data is going in now. And if you'll see, as I explained earlier, the NAs are the data that has to be corrected. It's currently not, I didn't pull it because we know that it's got a fix that has to happen with it. So I am very interested in whether anyone has had real success in being able to increase quadruple medication, any strategies that you might be using. As I said, it looks as though, in looking at the Philadelphia data, that is a real opportunity for us to kind of concentrate on. And so I'd like to just see if anybody would like to comment on any strategy they may have, or any process that they are using that they think might help them increase that quadruple medication.
Hey, Rhoda, I'm not sure if you can see that chat, but Rebecca Mountain had chimed in on some work that their organization is doing for adding Jardians to formulary. So Rebecca, I'm not sure if you're able to come off mute and share more. Otherwise, I can read what you put in the chat.
No, I can do that, and might be stealing Dr. Wald's thunder, but we recently learned that the UPH health system has approved Jardians for formulary addition. So we've not been able to start people on it in the hospital in the past. So there is not a timeline for, actually being able to order it. They have to add the order to pen chart and get it, the med in the stock in the pharmacy stocks. But the biggest barrier that we have with this is cost for patients, that they just can't afford it. So we've done some work with the pharmaceutical company who manufactures it, and they've given us some discount cards, but that doesn't help forever. But we've seen improvement in documentation of the barriers. The system reason like patients can't afford it, where they don't want to pay for it. So that's, I'm always curious how many people are actually on these medications, or have we just done a better job of saying that it's too expensive? But, I think it's the same thing applies to Entresto.
Thank you. Thank you for, I remember that Dr. Wall said that she was working to get it approved, that was one of the barriers. I'm delighted to hear that you guys have been able to do that.
I think it took a year.
Good gracious. Is that a normal time? Is that normally the time it takes for a system to adopt a change like that?
I would be curious to see what other people on the call have to say about that from other systems.
Yeah, I would be too. Is there anybody else on the call that has had some experience with this and getting medication approved and the time it takes to do that, or how they did that?
This is Lauren at LGH. We've actually had Jardiance on formulary for quite some time. So I think that that's why we've been able to be successful with getting it prescribed, because we've had Jardiance on formulary for several years already.
That's wonderful. Okay. You guys are in the same system, correct?
Yeah, I mean, we're all in Penn Medicine, but LGH is like our own, because we're not downtown or close to Philadelphia as everyone else. And we were initially taken in by Penn. We've had it on formulary for a long time.
Well, that does help me understand. So it's not a system-wide acceptance. Each site will have to, if they don't have it on formulary, will have to go and have it put on formulary.
Okay. LGH has had it on probably, I don't know if that was before you guys joined Penn or not, Lauren, but the other 5 hospitals, 5 entities, all sort of move as a pack and do things together. LGH is also on a different instance of Epic than we are, so they are able sometimes to enact things more quickly. And I would also just point out that a few years back, and Lauren probably knows when this was, they led the nation in the lowest readmission rate, and they are very kind of always out in front. And I know at our entity, we like to partner with them and look for their successes and adopt some of their things as our own. So I would just like to give kudos to them on that.
Wow, that's quite a accolade. I'm impressed. Very good. Well, that's a lot of good information. Thank you, guys. I also want to ask the next question, because I think as we go along and you see this data, you'll understand why I'm asking this question. How are we addressing health-related social needs being documented and tracked for patients? And what resources do you find most useful for patients? Rebecca, would you mind commenting on that, on how you're addressing the social, the needs related social needs and how they're getting documented?
We are actually not doing a good job of documenting social needs on the inpatient side in a formalized assessment that can be done in our EMR. However, our social workers and nurses are always keeping eyes and ears open, and all patients are asked if they have issues with getting their medications, but we're not delving into all the other stuff. That is some work that's happening at the health system level that was slowed down a bit by Omicron. And so each entity is now working on their own projects to utilize the assessment that exists. And I believe that it's sometime later in fiscal year 23 that it will be required documentation on the inpatient side across the health system. But that's all I know, only because I have done some digging into it.
So you guys have Epic. Did I understand that Lauren, you were saying that there's a different Epic for your site?
We just have a different instance of Epic. We also don't have pen chart that the other pen hospitals have. We work on a little bit different of a system than they do, so it's not exactly the same. Now, we do have a social needs assessment that is mostly utilized by case management, and then that is then placed in Epic, and based on a patient's responses, we would intervene with whatever resources we may have available for them.
And for us at Chester County, case management is making those assessments, but it's not, the data is not discrete, so it's not reportable. It's all, a narrative or texting or, just a narrative note. So we have no reporting that we can do from that. The social determinants of health needs assessment that's built into the nursing admission assessment is what exists, but is not currently mandatory for nurses to complete it.
Okay. That explains a little bit of what I'm seeing in terms of all the social needs being documented. I'm going to show you in a few minutes some information that I pulled out of the IRP on unmet social needs, and I can understand how we're not getting all of them now by your explanation, because you're not the only site that's having the challenge. Is there any resources that you find, what resources do you find most useful for your patients? Is there anything that comes top of mind? No, okay. All right, well, let's move on to the next. So I was just talking about those unmet social needs. So this is what we've done. Implement HF team, we've gone into the IRP and we've looked at what are the unmet social needs. Now I have one here for the 7 region aggregate, but I also have one for the Philadelphia area. This speaks to the 7 regions. And as you can see, the first, it says none. Most important, this is a bit 52%. Selected none. You can see all of the various needs, social needs or services required. And of course, this is early, this data actually was 27,935 patients needs were assessed, but only 5,473 are in here. In other words, there's a whole lot that is not here. The actual number is 2,847. So this is just a reminder that not all hospitals are collecting and documenting what the unmet social needs were. And as we did not require this from the start, but we're hoping to work a bit more on this. So we're going to be able to kind of flesh this out in the coming days. But we really think that the more we're able to document the needs, the unmet needs, we're going to be able to find the resources. This is, I think, key to us being able to increase those healthy days at home for patients and decrease our all-cause mortality, which of course is the vision and mission for Implement HF. So my thought is, when selecting how's the documenting being done? So when selecting none, does that mean that there are no unmet needs that were identified? Or maybe, as we're having in this conversation, those needs were not documented? Because when you look at this number, 52% is high, is a high number. And I'm thinking that maybe it's a matter of documentation. And actually, Rebecca, with the conversation that we're having, it makes me think that that is a good part of it. So let me hold on, let me look at this. So we first is none, 52%, substance abuse, 18%, education, 6%, personal safety, 5%, mental health, 4%, financial strain, 4, living situation, housing. I take that to be homelessness, but we didn't term it that way, so I guess I cannot decide that. 4%, transportation barriers, 3%, food, 2, employment, 1, and utilities, 1%. This is, of course, as I said, this is the 7 region aggregate. This is Philadelphia. Now, as I was saying before, we've got 4,649 patients records are there, but 1,582 is what is in here. So that leaves quite a bit that did not find its way into being documented. Again, we've got none. Is that because we're looking at there were no social needs there were no unmet social needs, or were there not documented, none documented? And I think I'm beginning to lean toward the not documented. So we have substance abuse in Philadelphia, mental health, and living situation. Again, I term that as being kind of housing or unstable housing. Does this seem logical? Does this seem in line with what you guys see? Lauren, Rebecca, do you think that this makes sense? Is this kind of the way you're seeing Philadelphia and your sites?
Well, I think what I would say is this pie chart probably represents the 1,582 patients who were assessed. And so what you're missing is the other, 3,000 who weren't assessed that would probably reconfigure this pie chart. So, I mean, that's a decent sample size, I would say. You have about a third of them assessed. So maybe that could be representative of the actual need, but there's a lot we're not capturing. There are some folks on the call from downtown. I see Michelle File. I don't know if she has any input on how this works with the downtown hospitals.
Hey, yeah, I was, we are in line with what Rebecca said as far as case management and social work on the inpatient side, performing assessments that are documented in a narrative format. So I'm not sure exactly what this data is that's being submitted for the hospital, the University of Penn here at 34th and Spruce Street in Center City. But I was wondering the same thing that we were all wondering are these just the patients who were assessed? And then I was also wondering if this says unmet needs, are we saying if they have a need that was met with some services, are they not being reported as an unmet need? So I'm a little bit confused about that. Maybe we're actually meeting the needs with our community health workers and our referrals to inpatient substance abuse treatment. And does that mean that that is not being classified as an unmet need because we do have case management, social worker, and community health workers meeting those needs? So I'm just not sure if this, what this data is telling me.
So let me give you the measure description, okay? It says patients with heart failure who are assessed for health-related social needs grouped by unmet social needs identified 30 days post-discharge. So documenting none should mean that none were identified. So the intent is the patient had no social needs. I'm not quite sure that that's how it's being, that's how it's being put in, that it's understood that way across the board by everyone.
Yeah, and I'm an inpatient clinical nurse specialist. I don't work with outpatient at all, so I'm not sure exactly how this is being documented for that 30-day follow-up.
I think it's something we have to, that's another opportunity to look at. So one of the things that I think would be helpful for the Philadelphia area, and please correct me if I'm wrong, or if you have a different idea, is I am thinking that you, based on just looking at this sample, and I agree, we have a large number of patients who we're not capturing data on. So that substance abuse, mental health, and living situation may change and would no longer, had we captured those patients, would may no longer be the top ones. But just looking at what I do have in my hand, I'm planning in November to have a kind of boot camp that would provide the Philadelphia area resources for patients who have substance abuse or mental health or living situation, homelessness, that type of resource that's needed. Is that something that would be of help, or would you prefer something else? What I'm trying to do is to provide you with some tools to be able to provide for your patients. Or does that make sense to you?
So
I don't see any case managers or social workers or a transitions coordinator, but knowing them, I would think that they would really appreciate knowing of other resources that are available.
And I think Rhoda, yeah, I mean, when we all had to send in names of people from our entities who were going to be involved in this work, you know, I talked to case managers and social workers who work with our heart failure population primarily, and they said, sure, just pull us in when it's time. So that would be something we would want enough advance notice so that they could plan accordingly to make themselves available for that learning. And the other thing is that, you know, the resources have to be accessible to patients. And so those maybe physical places where patients would go for assistance would be different in the city of Philadelphia than they would in the outlying area. Like I'm in the suburbs in Chester County,
Right.
and Lauren is out in Lancaster County. So we wouldn't expect patients from Lancaster and Chester County to access, you know, physical resources, places where they go in center city Philadelphia, because it's, you know, 50 and 75 miles away. So that, you know, it needs to be relevant to each
Your area.
area.
I think
Yeah.
I appreciate your saying that. And so in order to do that, would it be reasonable for me to use the zip code, say, and surrounding areas, the zip code and surrounding areas of your sites? That way I would pick up, I'm looking for resources that would be close, correct? Do you have
Yes.
another way you think would be better?
No, I think that would be it. I'm very familiar with the zip codes that are in the market zones at my hospital just because of other work that I've been doing lately surrounding that. I don't know that, because we have a pretty wide geographic area, as I imagine Lancaster General does. Also, I don't know about the downtown hospitals.
Yeah, we would have a large, I mean, even there are individuals that come from like out of the county potentially, like York County, and even like we'll have a couple of people even from Chester County that are on the border there, that, you know, could either go to Chester County or come to Lancaster. So there is a wide range there as well.
Well, we do have resources that allow you. We have Find Help that will, as been put in the chat, that will allow you to use the zip codes for your patients, and I'll get to that in a minute. What I was attempting to do is, it's one thing to get to know that a service exists, and I was attempting to get the actual contact information so it would be easier to connect patients with service. So that's what I'm trying to do. But let's move on to resources and upcoming events. I mean, as you can see, one of the big things that we're trying to do is to deal with these social determinants of health. And so Find Help is a very good tool for that. It's a tool that allows you, and as we were talking about, in your region, it will help with providing you the resources and the services in the region. And so the patient engagement component of Implement HF has been working to support heart failure patients and support the systems to be more engaging, to manage their conditions through shared decision-making tools and condition education and tracking tools and social needs and peer support. And as a component of Implement HF, we develop a patient advisory group, and it consists of heart failure patients and caregivers and clinicians. And this group's work is that together over the last year, they've been supporting the initiative by providing the insights and feedback about the priority items that can be developed in the patient engagement tool. And one of that is the Find Help. And that's what we've got here on the screen. And Find Help is a social care network. It's a research tool that enables anybody to find the resources across the spectrum. That's food and transportation, housing, and more. And Find Help used to be called Aunt Bertha, for those of you who are familiar with that. And Find Help has got two implementation models. The first is simply providing, they'll give you a URL to anybody in need so they can do the search themselves. And the second allows anybody on your team to use the platform to help patients identify the needs and to make a referral directly and track the referral outcomes. So what we've done is we've set up a unique search URL for each region, and I'll click on it in a minute. There is one for Philadelphia, and what we're hoping to do is it'll help us to understand the needs of the geographic region. So when you give this URL out, we'll get data back, and it'll include the URL we're providing. Just go ahead and click here. Well, this is the two ways to connect. Here we go. The URL right here at the bottom. Here's the Philly one. The URL will provide us some information about the most common searches and the top zip codes that you search. And we also have some postcards available with that unique regional website for distribution to your patients. So just to let us know. This is a real good resource. And so share this resource with your patients. And if you're interested in leveraging the platform for your organization to create a profile, you can make referrals and track patients' follow-ups. So let me go back to this one here. So you can use the Find Help platform to refer patients to resources. And you can put in as little information as their name and their contact information. So when you submit a referral, the person that you're sharing the resource with will receive an email or a text with the information about the program and the next steps. And the organization that they are providing, the community organization providing that program, receives an email with the contact information of the person you're referring. So that is a really good resource, and it's two ways. And what I like most about it, it doesn't require you to put a lot of information. I know that patients, having worked as a social worker at once in my career, some patients don't want a whole lot of information they don't want to offer a lot of information about themselves. So it's a limited amount of information that is needed to be able to provide that. So that's your unique Philadelphia URL. And so the next is, this is the the Mended Hearts program. I'm sure you may remember, My Heart Visit is Mended Hearts. It's a 12-week program offering peer-to-peer support to help with recovery and transition back home. And the goal is to improve patient outcomes and, of course, reduce hospital readmissions. This again, too, is uh, the patient heart failure helper. And this is a new app for patients to help them manage their heart failure. They can download this free from Apple or Google, and it lets them track their symptoms, better or worse, their medication management, the vital signs, nutrition. Um, and they can also take that tracking, that it's a way of tracking medication adherence, and that can be shared with their physician. Of course, again, this is another one of those opportunities to use zip codes. This is another resource, again, trying to help with those social determinants of health, that how to get patients connected. One of the discussions we had about the cost of medication, SGLT medication, not only do they have you can see the variety of medications: diabetes, infectious disease, cardiovascular, mental health. But Dispensary of Hope collects and distributes millions of dollars of pharmaceuticals annually to pharmacies and safety net clinics, and they're dispensed to low-income, chronically ill patients. And so it's a national network of nonprofit organizations that are licensed to dispense medications directly to the patients. So this is another opportunity or resource for patients. Needy Meds. Needy Meds is another resource for prescription assistance. And of course, that's the link is there. They connect people with healthcare resource patient assistance for prescriptions. They have patient assistance for prescriptions as low as $4 for generic, or there's you can get a drug discount card anywhere from $4 to $15. And the most of the clinics that they have referrals to have a sliding scale. So they have medical, dental, mental health, substance abuse. They have diagnosed based programs. And as I said, they have a drug discount card. They also have patient education that's available on their website that you'll be able to access. So this is a little different than all the resources that I've given before. This is just a reminder about the Implement HF Healthcare Network that was launched. By now, everyone should have received an email invitation to sign up. It is a free login when you join the network. And please reach out if you haven't gotten that email. We thought we caught everybody, but there's always changes on staff. So if by chance you haven't, please just reach out to me and we'll make sure that you're signed up. This is exclusive to Implement HF participants. And our intent is that this is a one-stop shop where you can access all the Implement HF resources. So that means that the collaboration calls are there. These slides will be there. Any webinars we have there. And we're working to get all of that uploaded. In fact, I know that the collaboration calls, the 7 region collaboration calls are there. And they're also designed so your region, our region, the Philadelphia region, will be easy for you to see. You don't have to do a whole lot of sorting through. There's an opportunity by going to the network that you're going to be able to ask any question that you've got, and to have the ability to create a discussion thread, a forum where other people can chime in about what they've been able to do, their successes or their challenges. So we're really hoping that it's going to be useful for you. And if you have any specific heart failure related question or discussion that you'd like to see us to approach, please let us know. We're certainly happy to do so. And we're also happy to know what it is that you need, because if you don't tell us, we're not in the trenches with you, though we try to be. We just don't know. So So what I've included is we've had some model shares on the regional calls. So if by chance you have wanting to know how are other sites managing to capture that 30-day follow-up data, well, the January 27th call had these folk on that are listed below offered their suggestions and how it worked at their facility. That you can find those broken out into those model shares. You do not have to listen to the whole January 27th call. You will be able to go in and simply listen to what they had to say about how they're collecting that 30-day data. So that's some of the model shares that are on the Implement HF network. Here's another one. So this is the electronic health record, the EHR quality improvement tools for the April 26th call. These folks shared on that call how they were using EHR in terms of quality improvement. So again, you can find that on the network. Just a reminder, we will be at HFSA. I hope you guys will be there. If you are, please come by the booth. We're looking forward to seeing you. And of course, the registration link is there at the bottom. Please stop by, and we always love any opportunity to meet you face to face. Okay, we're going to have model sharing at scientific sessions. That's November 5th through 7th at McCormick Place. And we'll be hosting a quality showcase, and we've done that in past years. Again, we'll be featuring Implement HF model shares, similar to what we did at AAHFN. And those sites that submitted theirs before, we'll have them there for AAHFN to be seen again. So we'll also be providing travel attendance stipends to those who submit model share, and of course we'll be back in touch with some more information. But I'm always happy to work with any team that wants to put together any model share or poster. But we'll have more information going forward. So these are just the Get the Guidelines Heart Failure IRP updates. So I just want to go through these. Basically, the carefree quadruple medication therapy measures that are what we've been looking at. So that AHA-HF 106 is a inpatient measure and 107 as a 30-day measure. And if you've been pulling the reports internally for reporting, keep in mind that the old measure that you're pulling before will be retired as an Implement HF measure. And it was pulling data a little different than the original. Instead, it's still a helpful measure, and we'll be keeping it going forward, but you'll be able to pull these two measures. The old quadruple medical therapy measure did not look at measures as a composite. These are the new measures that we'll be using. But we will keep the old measure around just as it creates a different kind of view of the data. And you can look at the measure descriptions in the library for these to see how they're different and what the inclusion-exclusion criteria is for each one. The composite measure takes the sum of the existing measures of heart failure 2, 5, 6, and 93 and gives you a composite score instead of the pass-fail that we have scored previously. So for the health-related social needs, there was an issue with the carry forward on the inpatient form. So now that should be working on the 30-day form now, and there will be some additional fields that have been added to the 30-day form. But more granularity around the cardiac rehab or heart failure disease management programs that are described at discharge or at 30 days. And those are just optional to collect as they were previously. Again, this is just the reminder for the upcoming events. The HFSA event at the end of September, I mentioned. Our next regional collaboration call, October the 25th, and scientific sessions, November 5th through the 7th. Is there anything anyone would like to add or ask, comment on? We have a little bit of time, have 6 minutes. You guys are very quiet today. If you think of something that you would like added to the agenda for our next call, or something that you would like further clarification about, please don't hesitate to reach out. You know where to find me. You can clearly see my name there, but at this point, I think everyone knows where to find me. So if no one has any comment or anything they'd like to add, I think we can just call this a day. I can wish you the rest of a good day. Hey, everybody. Thank you so much.
Thanks. Bye-bye.
Bye. Thank you.
Thank you.